Thank you very much, Dr. Tung. Uh, because my topic is so wide, it's quite difficult to cover it. So I intend to go through an approach and delve through some subjects in further detail. So young ischemic stroke is generally defined as 18 to 50 years old. The upper limit can vary from 45 to 55, partly depending on the population you study. Those with long survival rates usually use up to 50 years old. And young strokes represent about 10 to 20% of all ischemic stroke. And this works out to over 2 million young strokes yearly. Now, this is quite important because of the social economic impact on the individual, the family, and the society, as these patients are often in the prime of their working life and still have a long life to live. And this is even more worrisome because there is now a trend towards increasing strokes in young adults. Worldwide, there is up to 50% increase in the incidence of young stroke in the last decade. And this incidence varies between countries, with the highest incidence found in developing countries. Furthermore, young ischemic strokes have a high risk of recurrent ischemic events. The future study, which was run in Netherlands, showed that the recurrent risk of ischemic events after the first stroke, the cumulative risk over 20 years was almost 20% of a second stroke, and of any cardiovascular event, it was up to 30%. And you can see from this chart that the highest risk of recurrent stroke and cardiovascular events is in the first few years after stroke, and thereafter it plateaus down. And in this study, 50% of the young strokes had large artery, small artery, or cardiac causes. What the authors surmise is that the original disease that caused the stroke is probably still contributing to recurrent events. And the recommendations that if you do have a young stroke, do keep them on longer term follow-up to make sure everything is well controlled. The GOAL study it's a pool analysis. They took individual patient data from various cohort studies and they looked at the association with stroke. The aim of GOAL was to identify the contribution of ethnicity, race, region, and economic situation towards the development of young stroke. So it had over 17,000 patients from 29 countries. As you can see, mean age of stroke was 40. Men were slightly older than women. And in this analysis, Asians were very well represented. However, 80% of the study came from high-income country, 20% low-income country. This included India, Mongolia, from Asia. And what they found about Asians were that, one, Asians were more likely to have traditional cardiovascular risk factors. They had hypertension, diabetes, they were more likely to smoke, and they were more likely to drink alcohol. But not surprisingly, Asians were also not obese. As you can see, most of us are not at all obese, and Asians did not tend to use illegal drugs. They also found that women had less traditional risk factors than men because we tend to look after ourselves better. We know that. But women were more likely to have PFO and migraine. When you look at the overall TOS distribution for the whole population, you find that about 30% was due to large vessel and small vessel, cardioembolism 20%, and almost 50% were due to other causes or undetermined etiology. But when you look among Asians and in Asia, Asians and in Asia, you realize that Asians had more strokes due to large artery disease and small vessel disease, up to 50%. Not surprising considering that we have so much traditional cardiovascular risk factors. And there were less cardioembolic strokes and strokes due to other etiologies. Lower income countries had more other etiologies and undetermined, partly probably because they didn't have the facilities to investigate intensely. If you look at the distribution of stroke according to gender and age, then what you find is that men tended to have more large vessel and small vessel disease, especially when they are in the older age group. So among the older age group. On the other hand, women and younger age group young strokes were more likely to have cardioembolic strokes and other etiology. So just to summarize, What Gold told us was that 50% of strokes in young populations are due to other etiologies or undetermined causes. And with younger age, cardiac causes and other etiologies are more common. As you grow older, it's more likely that they have traditional risk factors, and large artery stenosis and small vessel disease are more probable causes. Women always think of PFO, especially if they have migraine. With that, I'd like to move across to the approach to young stroke. It's actually not much different from the regular approach to a elderly patient with stroke. We always start with a detailed history and examination because that, in a way, drives the standard investigation. Without doubt, we prefer to do a MRI over a CT because it shows acute infarcts better and allows us to identify small infarcts. Now, vascular studies are very important in strokes because of the other etiologies. So we like to study the cerebral vascular access the whole way. CTA from origin of common carotids right into intracranial. You must know the limitations of the tests you use. For instance, if you use ultrasound and transcranial Doppler, you must be aware that there are some parts of the cerebral vascular disease that cannot be insulated, and you might need to do another form of imaging to look at those parts. Especially if the patient has cardiac symptoms like palpitation, you would do rhythm or structure monitoring. If all vascular studies are normal, you may want to consider echo with bubble or transcranial Doppler with bubble to look for evidence of paradoxical emboli. Traditional blood tests for standard cardiovascular risk factors should be performed, but because these are young strokes, we usually tend to also order autoimmune panel. We also always send drug for toxicology because young patients who use drugs are not likely to tell you the history. An infection screen will depend again on the underlying history. If these tests do not tell us more, or sometimes when they do guide us down, we may want to do further contrast imaging or even a high definition MRI imaging to look at a wall. We may want to do a prolonged cardiac rhythm monitoring if there's a history of palpitation. And if the paradoxical emboli is present, we may want to proceed with a transesophageal echo. Other more detailed blood tests can be considered, and lumbar puncture to rule out CNS vasculitis. We may need to consider brain biopsy to confirm it. And if malignancy is an issue, you may even want to do a pan-body scan and such. So the next stage will be the comprehensive, which hopefully can be driven by your initial screen. So I'm going to approach this segment of my talk according to the etiologies. Hopefully, we can do a comprehensive evaluation, so most patients won't fall in this category. But I would like to focus my talk on this topic, stroke of other determined etiologies, and briefly only go through these. So radiation therapy is good, especially for cancers that are inoperable. But unfortunately, one of the long-term side effects of radiation therapy, whether it's to the head or neck, is accelerated atherosclerosis, especially if these patients survive long enough. In our region in Asia, the common cancer of the area is nasopharyngeal cancer, and most of these patients receive neck radiation. And usually accelerated atherosclerosis starts showing up after 5 years. You will see at least unilateral severe carotid stenosis involving the common carotid and ICA. And these plaques that you can see are long, extensive, and ulcerated. So these should be screened when the patient gives you a history of prior radiation. We rarely see intracranial stenosis from radiation, probably because most patients don't have a good prognosis with that. Now, cardiac source of investigations. A UK study looked at young stroke, and out of 24% of their young stroke had cardiac causes, and you find that almost 10% was due to a patent foramen ovale. Then the remaining common causes were atrial fibrillation, heart failure, and valvular heart disease. So moving on to patent foramen ovale, neurologists has always known that PFO was more common in cryptogenic strokes than in the normal population, where it's only found about 25%. However, in the past, we had no good treatment. All the studies were negative, so there was no need to search for it. However, in the 2017 and 2017 to 2018 were all the closure trials that showed there was an effective treatment. So now, if our patient is a young stroke, and if the initial tests do not suggest there's an underlying severe stenosis, then it's reasonable to proceed to look at the ROPE score to identify patients who might have PFO as a cause of stroke. And this is the ROPE score. And you can see from here, if your patients score a high ROPE score from 7 to 10, then the chances of them having a PFO causing their stroke really increases up to 70% to almost 90%. In our center, we like to screen for paradoxical emboli, right-left shunting with transcranial Doppler study. And if this is positive, we will ask our cardiologist to come in to opine. And they usually would like to do a simple thoracic echocardiogram because they don't want to be surprised by other cardiac conditions like myxoma. And if that's negative, they will proceed to offer the patients a transesophageal echocardiography with bubble study with view to closure. We don't always do an ultrasound scan to look for a deep venous thrombosis unless the patients have a history or their legs are obviously swollen. We don't always do a thrombophilia screen to look for increased risk of thrombosis too, venous thrombosis. And that's because the evidence here is lacking. So this just to show you how we see the bubbles here and in the transthoracic echo. As I said, in the 1970s to 2017 to 2018, there were trials that showed that PFO closure was associated with a 60% lower risk of stroke compared with non-closure. The absolute risk of stroke in both arms was still very low. And PFO closure is more beneficial if your shunt is large or if you have a concomitant atrial septal aneurysm. You need a good surgeon because there are complications rate and there is an increased risk of atrial fibrillation, though it usually resolves within the first couple of weeks. However, because these are young strokes with a long lifetime in front of them, we usually would always refer them to cardiologists with view to closure. Now, moving on to stroke of other etiology, I'd like to briefly go through dissection, FMB, moyamoya disease, and RCBS. So dissection, a study showed, tends to occur 90% of the time. They occur in the distal half of the extracranial ICA. In only 5% of the time, does it involve the proximal 1/3. Now, this is important because you must realize that when you do an MRA circle of Willis, you usually image the ICA only up to this part. If you do your extracranial with an ultrasound, you only study the carotid up to here, and you have a blind window here, which is not imaged. And you may want to consider filling that in with a CTA or MRA carotids. Otherwise, you might miss dissection involving this part of the extracranial ICA. And it is believed that the red tail that you see is due to a distal severe dissection, and then proximally there's a collapse. That's why you have the classic red tail look. And it has also been observed that dissection commonly occurs in patients with very tortuous ICA, kinks or coils. The prognosis for dissection is very good, however. 85% of them on follow-up will show full recanalization. So this is a picture showing you the rat's tail. And here, afterwards, thrombectomy, you can see the flap. Here you can see an MRA circle Willis, and the ICA enters the bone just before the horizontal segment, and you can see stenosis here, and on the short axis, you can see a flap in between. So this is involving the distal 1/3 of the ICA. And here you can see quite clearly, involves the distal 1/3 before it enters the bone, and proximally it comes down. This picture just show you very good recovery, most patients after a few months. Intracranial dissections, according to published reports, are way less common than extracranial dissections. But interestingly, Asians seem to report more intracranial dissections than the Western, leading some authors to believe that Asians are more predisposed to intracranial dissections. Patients can present with headache, ischemic stroke, or hemorrhage. And that's because the intracranial vessels, intracranial carotids, as well as vertebrals, the adventitial layer is very thin. So if the dissection occurs between the medial and adventitial layer, it can rupture and cause hemorrhage. Whereas extracranially, the adventitious layer in the extracranial carotids are quite thick, so they rarely rupture. When you do see dissection, you should always think of conditions that predispose you to dissection, including the connective tissue disease as well as fibromuscular disease. So next, I'll go on to the fibromuscular disease. We don't know the cause of fibromuscular disease. It's idiopathic, segmental, not inflammation, not plaque, and tends to involve medium-sized arteries. It's often associated with tortuosity, stenosis, occlusion, and aneurysm. Most common arteries, as we know, are the kidneys, which is why patients present with hypertension, and in the head, extracranial ICA and vertebral arteries. Up to 40% of cervical dissections have fibromuscular dysplasia. And it is a disease that's more common in women, up to 80-90%. Now, the diagnosis of fibromuscular dysplasia depends on you identifying two things. Either multifocal fibromuscular stenosis, in which case you see a string of beads. You must see it in at least one vascular bed. If you don't see the multifocal FMD, you must at least identify a focal FMD, where you just see a focal stenosis, and then with maybe a bit of a dilatation. If you see one or the other, you can diagnose fibromuscular dysplasia. Even though it's commonly associated with aneurysm and tortuosity, aneurysm and tortuosity by itself is not diagnostic for FMD. And like I said, dissections are commonly seen. Most dissections have aneurysm, have tortuosity seen in the earlier study. Moyamoya disease, we know quite well about it. It is an intracranial stenosis involving the terminal ICA, proximal MCA, and proximal ACA. And with time, it progresses. As it progresses, you see downstream, ICA collapses until both ICAs are gone. It was first described by the Japanese, and this is the angiographic staging first described by them. As the terminal ICA occludes, you have collaterals forming, but when the occlusion is very severe, all the collaterals are gone, and the ICA becomes very small. Nowadays, we rarely do angiogram because we have MRI, and the IV sign is described on MRI. On FLAIR, you see dots and lines, and these are believed to be due to engorged veins. If you give contrast, you can see the squiggly lines and dots, which they think are either thickened leptomeninges or engorged pier vessels appearing more prominently. Diagnostic criteria for Moyamoya disease is quite well described. To be Moyamoya disease, you have to be bilateral and you have to exclude secondary causes. Nowadays, we rarely get histological findings. And you know, the epidemiology is well described in Chinese, Japanese, and South Korean. Bimodal, children, and then in the 30s and 40s. And in the first decade, children tend to have more ischemic infarct as the arteries occlude, but in the older decade, when the collaterals come up, they're more likely to rupture. So you see ischemic infarct and bleeding equally. We like to use MRI high-definition wall imaging to help us differentiate between Moyamoya disease, atherosclerosis, and other conditions, because you look at the wall instead of the lumen. Now, if this is a normal vessel, what happens in Moyamoya disease is you have negative remodeling. The artery always shrinks. It will be a concentric shrinkage with very little enhancement. On the other hand, most times when you have plaque, it is a positive remodeling. The artery usually gets bigger. It is always eccentric because of plaque, and the plaque may enhance erratically. Vasculitis, the artery size remains the same, but there is strong enhancement. Reversible cerebral vascular constriction syndrome, they don't enhance much. Just to show you the negative remodeling in Moyamoya and the positive in the plaque, and the concentric enhancement here, and the eccentric enhancement patchy in an atherosclerotic plaque. The RCVS syndromes are believed to be due to cerebral dysautoregulation. I just want to highlight, if you see a young patient who gives you a thunderclap headache, I know you think about subarynoid hemorrhage, but if subarynoid hemorrhage is excluded, then you think about CVS, especially if there's no bleed. The patients may have normal findings and they're more likely to be female. And in your history, you may find triggers. Triggers are related to the female hormone state, postpartum, pregnancy, preeclampsia, or they've bought drugs that contain vasoconstrictive agent, cough mixture containing phenylepinephrine and such, or they've done some very strenuous activities, including sex and strong Valsalva maneuvers. So if you get a history of triggers, that makes you suspicious. But on imaging, you will find all kinds of findings. The most distinctive finding, of course, will be the fact that you see vasoconstriction that starts from periphery and gradually come in. Over 1 to 3 months, the stenosis, the constrictions just recover, move in, and they generally tend to recover all by 3 months. The RCVS2 score was proposed to use to increase the sensitivity of diagnosing RCVS once you've excluded subarachnoid hemorrhage. It consists of thunderclap headache, intracranial carotid artery. It should not be involved because it's rarely involved in RCVS. If you get a history of a vasoconstrictive trigger, sex, and bleed. So you find that if your score is above 5, it's very, very likely you have RCVS. And if it's less than 2, it's likely due to other conditions. The inflammatory vasculitis includes the autoimmune disorder that we rarely manage by ourselves. We will always consult with our hematologists who are the specialists. Infections that my co-speaker will speak later about, and drug abuse that we rarely see in Asia. I'll go through them briefly. So autoimmune disorders can be primary vasculitis, or the vasculitis can be due to other systemic disease, or the vasculitis can be localized to a single organ. The symptoms can be very vague, and that's why when we have a young stroke, we tend to send the blood tests because the symptoms can be vague. You may feel absent pulses in Takayasu disease, but these are some of the blood tests that we would consider doing. About 5% of the population uses illegal drug, and there's a 6 times increased risk of ischemic and hemorrhagic strokes. Hence, we always send toxicology screen the blood and urine for young stroke. Drugs can cause stroke through many mechanisms: vasculitis, vasospasm, hypertensive spike, prothrombotic states, using dirty syringes, causing infective endocarditis and such. So the causes are multiple. The drugs that are associated with strokes are usually the stimulants, such as cocaine and amphetamines. However, the hallucinogens have also been associated with strokes. Recently, Amsterdam reported an increase in the abuse of nitrous oxides, which is the laughing gas. And what it does is that nitrous oxides oxidizes the vitamin B12, makes it dysfunctional. Most of these patients will then have elevated homocysteines, and they're at an increased risk of arteriovenous strokes. And of course, the drugs that we use for therapeutics may also increase our risk of stroke. Thrombophilias and blood problems, hereditary conditions, all these hereditary thrombophilias have not been definitely associated with strokes. The evidence for it is weak. We may consider doing it in patients with PFO because these patients are presumed to have a venous clot somewhere, but the data whether we should screen them in all PFS stroke is missing. And of course, acquired thrombophilia, the most important is the antiphospholipid syndrome. These patients would give a history of pregnancy complications. They will present with arteriovenous thrombosis, and there's specific antibodies in the blood that should be present. What you must be aware is if you check the blood test in acute stroke, it may not be so accurate. You might need to repeat the test about 3 months later to make sure that they are truly present. The other blood conditions can cause strokes. Most commonly is the hyperviscosity, those with too much cells and clogs up the blood flow. And malignancy related. Cancer is associated with stroke, not all cancer, lung, pancreas, colorectal. Again, the causes are many. Prothrombotic states, association with non-bacterial endocarditis, tumor invasion of arteries. and treatment side effects. A Norwegian study found that about 4% of patients who presented with stroke were subsequently found to have cancer within 1 year. And it is estimated that 10 to 20% of cryptogenic stroke will have cancer diagnosed in 6 months, which is very difficult. How do you diagnose? When do you search for cancer when there's no clue to it? One study proposed using D-dimer as screening and a history of smoking, but that's really too vague and it's not clear. So we generally would do a CT screen for cancer if our patient's cryptogenic and can't find a cause. What you need to be aware of is that cancer survivors remain at an increased risk of strokes. They are 1.6 times higher than normal people to have strokes, especially if they are cancer survivor from head and neck, blood, lung, pancreas. And ischemic strokes are more common. Furthermore, venous thrombosis are also more common in cancer survivors. And lastly, genetic and other problems that I will not talk about. So, ladies and gentlemen, that was a case I was going to discuss, but interest of time, I'm just going to pass it. The causes of stroke in young is very varied, and because some of them are so specialized, it is also a multidisciplinary approach to young stroke when you have suspicion and you need your expert colleagues to come in and help you. Ideally, we should do a stepwise comprehensive evaluation to save costs. Most centers tend to blunderbuss and order everything because it's easier to order and forget. But when you have a cost restraint, you might want to consider stage-wise investigation. Thank you.